Hello everybody, welcome back to Chapter 9. We are going to continue our conversation about the respiratory systems. Thus far we have compared different models in insects, in fish, and what I want to do in Part 2 is continue that trend. And let's take a look at some amphibians, some reptiles, and definitely some mammalian models. Alrighty, so let's start off with our amphibians. Now, when you do the amphibians and you compare their respiratory systems, what we see is oftentimes you'll come across three main types. They can utilize their skin through cutaneous respiration, they can utilize external gills, and there's often also a case, like especially with frogs and toads, that they will have a lung system that's set up. And this can vary from very simplistic in structure, just a few infoldings, to a more complex structure. Often as well, we see that they'll utilize a combination. So for instance, they'll use their cutaneous respiration and the gills, or the cutaneous respiration and the lungs. Ventilation in amphibians tends to be through a tidal, meaning it goes in and out through the same chamber. And more importantly, or I should say more uniquely, they will be utilizing what we like to call buccal pumping. And that's all going to be due to this little cavity that they have within their mouth region, which I'm going to highlight for you in 1 second. In addition to the buccal pumping, amphibians are also known to be intermittent breathers, meaning that they don't have to have a regular inhaling and exhaling pattern, as we see, for instance, in humans. They can quite alter they can fluctuate their pattern quite a bit, only allowing for gas exchange to occur when it's needed from time to time. Now, let's go ahead and explore this whole buccal pumping that I was mentioning to you before. And what's best to do is to go ahead and take a look at our illustration at the bottom. And we see our little frog sitting over there. And what we're going to notice is that within the oral cavity, it's going to have a little buccal cavity that's towards the back of the mouth region. So it's right over here. What we see happening is when air flows in, it will flow in either through the mouth in case the mouth is opening, but it will also flow in through the nares. So think of the nares almost like little openings for the nostrils, for the nose. Now, initially what we see is when we're going to do an inhale and inspiration, that the air will freely flow either through the mouth or through the nares into the oral cavity, and it will go ahead and it will sit in that little pocket of the buccal cavity. So all the fresh air that came in, if you follow the little black arrow, will sit within the buccal cavity. Once the buccal cavity is filled, what we see happening is the air can't go anywhere because there's a little flap of tissue called the glottis that is shielding the lungs. So that means that the air has nowhere to go but stay inside of the little buccal cavity. Now, our second step says that once the buccal cavity is filled with air, then the glottis will go ahead and open, and when it opens, we see that the lungs will go ahead and utilize their elasticity to basically compress down, allowing for the air that was in the lungs, I'm going to call it expired air because it's been depleted of the gases that needed to be utilized. It allows for the expired air to then pass through the oral cavity and exit into the environment. Okay, so air is forced out of the lungs and out of the nares. Now, at that point, once the expired air is gone, we see that the nares will close off, the glottis will remain open, and then here's where the buccal pumping will come in. We're going to raise the floor of the buccal cavity, and this is going to create a pumping mechanism that's going to allow the air from the buccal cavity to glide past the open glottis into the lungs. And once it's in the lungs, then what we see happening is our final step is we're going to close off the glottis, allowing the air to now freely exchange gases within the lungs. And keep in mind, as this is happening, we basically go right back to step number 1. So fresh air is already entering into the buccal cavity, and it's just waiting for the glottis to open to release the expired air so it can have its turn going into the lungs and doing its gas exchange. So when you utilize buccal pumping, that basically means that you have a buccal cavity, and in order for you to utilize the air that sits there, you're going to have to compress and you're going to have to raise the floor of the buccal cavity, thereby generating enough pressure for the air to get out of the cavity and flow into the lungs. When we take a look at reptiles, oftentimes we see that they will have lungs. Most of them have two lungs. They can come in different formations. Some of them are highly divided. Others have more of a few curvations. They kind of look like a little honeycomb. It doesn't really matter how many they have. The main purpose is that anytime they'll utilize any type of folding mechanism, the main purpose of that is to create surface area. And as you can imagine, the better you are at creating more divisions, the more surface area you have, so more effective you are at extracting your oxygen and taking out your carbon dioxide. Most reptiles will go ahead and utilize tidal ventilation, so the same chamber to enter and exit their gas exchange. You can also see lots of different suction pumps. It's basically similar to the buccal pumping in that it will generate a pressure, especially during inhalation, that will allow for the air to kind of flow in a more effective manner from point A to point B. I want to show you a little picture of different reptiles so we can take a look at how they'll do their inspiration, their inhale, and their expiration, and how many of them will rely on things like muscles and changing the volume of the chest cavity to create different pressure gradients that can then be used to allow the air to flow in and flow out. So for instance, on top right here, we have our little lizard, and what we see happening with the lizards is that it is able to utilize its intercostal muscles, which are the muscles that sit in between the ribs, and it's basically using those muscles to go ahead and expand the ribs so that it can literally suck in the air when it's inhaling, and when it's ready to exhale, it basically causes the ribs to move a little bit backwards, compressing the thorax, so it's almost like you're squeezing out the air. And by doing that, by controlling the volume of the thoracic region, you're also comparing the pressure points, making it easier for the air to flow from a high to a low pressure point, which we know is the preference that we see with lots of fluids within the body. I also want to mention that your lizards can also utilize buccal pumping, very similar to what we saw with the frogs. Now below the lizard we have a little turtle, and what we see happening over here is that with the turtle we don't really have buccal pumping. Part of that is because of the fusion between the ribs and the shell, so it's going to utilize another mechanism to increase and decrease its thoracic region, and that's going to be due to the movement of the different abdominal muscles as well as some of the lymph muscles. And as the animal is moving from side to side, it contracts and relaxes these muscles, allowing for the volume changes to occur to suck the air in during inhalation and of course expel it during exhalation. The last ones on the side right here, those are little crocodiles. With the crocodiles, what we see happening is that very similar to us, they have this muscle that separates their thoracic cavity from their abdominal cavity. We call it our diaphragm. They call it their diaphragmaticus, so it's a little bit of an extended name, but it's the same concept. And just like we do, what we see happening is that they will contract the diaphragm in order to assist the expansion of the thoracic cavity, allowing air to flow in. And when the diaphragmacus relaxes, it restores the thoracic cavity back to its normal size, and with that, it squeezes the air out when it does its exhalation pattern. Now, what about birds? Birds are unique because in order for them to fully utilize their respiratory method, they're actually going to have to take 2 inhales and 2 exhales. I'm going to show you what I mean with that in just 1 second. I have the diagram set up for you on your next slide. But before we get there, let's just take a look at some of the anatomy that we come across in the respiratory system of the birds. So first off, their lungs are relatively stiff. They don't like to expand. They're not as elastic as we would like it to see. And in addition to the lungs, you're going to notice that I've also put a little red box around the anterior and the posterior air sacs. Now, these air sacs are going to act almost like bellows, meaning that they're going to allow us to store the air on a temporary basis. And what we're going to talk about is the fact that when the gas comes in, it's going to go ahead and pass through the trachea and through the bronchioles, the parabronchioles in the lungs. And when it's doing this, it's going to do it unidirectional because we're going to use a different method to get the air out during our second exhalation. This all has to do with the fact that we have to do 2 inhales and 2 exhales to maximize the amount of gas exchange. Also, I want to highlight the fact that when we look at the blood flow, it is not cross-current. It's not counter-current. It's what we call cross-current. Cross-current means that instead of it running anti-parallel, it will have almost like a diagonal type of movement. So, for instance, on your little screen, I know it seems like I'm just drawing some random lines, but this will represent my blood flow, and then the airflow will kind of move through it in a linear aspect. So the fact that the blood flow moves more in a cross current, more in a diagonal pattern, that's what we're seeing. It is also a very effective way to, in essence, drag the oxygen out of the media stream and then add the carbon dioxide from out of the circulatory system. All right, so here are your 2 cycles of inhalation and exhalation. Okay, now during our first inhalation, what we see happening is the chest of the bird is going to expand. And as it's expanding, it basically is going to allow an increase of air to flow into the body of the bird. And look what happens to the air. It goes all the way in the back to the posterior air sac. So with the first inhalation, you expand the chest, and you allow air to be sucked into the body, and the air goes all the way to the back by the posterior air sac. Then you're going to do your first exhalation. This is step number 2. When you do your first exhale, what we're going to do is we're going to push back the chest. We're going to compress it back to its normal size, and that squeezing mechanism is going to allow the air now to go from the posterior air sacs into the lungs. So as you can see, we've moved from the back to where the lungs are located. Our second inhale, my apologies. Our second inhale is going to do the same movement with the chest that we initially saw. We are going to expand the chest. And when we expand the chest, we're going to use that pressure difference that were created to now take the air that's been sitting in the lungs. So it has done its gas exchange. It's now what we call expired or stale air. We no longer need it. It's going to allow the stale air to move from the lungs into the anterior air sacs. And then finally, when we do our second exhale, that is then when the stale air that was sitting in the anterior air sacs is then exited out of the body. And it's able to do that because, once again, we're going to cause the chest to compress, so literally squeeze, creating a pressure difference that will cause the air to flow out. So let's do this one more time. When you do your first inhale, air comes in and it goes all the way to the back of the posterior air sacs. Then you do your first exhale, and now air goes from the posterior air sacs over to the lungs. So go ahead and do your gas exchange. Then you're going to do your second inhale, and that's going to allow you to take the air that was in the lungs that you're now done with and move it to the anterior air sacs. And finally, our second exhale means that we go from our anterior air sacs to the outside of the body into the environment, and we are done. Now, what you want to keep in mind is that the air sacs are never really empty. So what that means is, while you are doing your inhale pattern for the birds, the bird is doing a first and a second inhale all at the same time, meaning that the first inhale is going to concentrate on taking the air and moving it to the posterior, and then the second inhale is taking a look at a previous inhale you've had, so it's already moving the air that was in the lungs into the anterior air sac. And then when you do an exhale, it's doing a first exhale and a second exhale, because the first exhale will concentrate on the air that was in your posterior air sacs, moving it to the lungs, and the other air that was sitting in your anterior air sacs is now being expelled out of the body. So these inhales and exhale patterns, when you hear me say a first and a second, it means that we're looking at the same batch of air moving through the system. but the bird itself will utilize both primary and secondary inhalation and primary and secondary exhalation at the same time, because there's always some air that is moving around its body. Now, when it comes to mammals, and this is where we get involved, we see that we tend to have a very complex respiratory system to the point that it's often subdivided between upper and lower. Upper usually indicates anything that is by the head and up to the shoulders region. So we're thinking our mouth, we're thinking our nasal cavity, we're thinking our pharynx, we're thinking our trachea. The pharynx is kind of like the back of the neck or the back of the throat region. And then the lower respiratory tract, that's going to be in your thoracic cavity. So that is where we're going to be able to find our lungs, our bronchioles, and our actually alveoli, which are the functioning units of the lungs. That is where you'll have your actual gas exchange that will come into play. In fact, what I've done for you is on top of your PowerPoint right over here, I kind of wrote how air likes to flow. So it will enter through the mouth or through the nares, those are your nose openings, and it will go ahead and pass towards the back of the throat region, that is the pharynx, passes the larynx, which is your voice box, that's that vibrating part you feel if you take your fingers and you put it down the middle of your throat, that's vibration you feel when you talk, that is the larynx. So it will pass the larynx and then it will go into the trachea, which is your windpipe. And then the trachea will subdivide into bronchioles, and as it subdivides, it gets smaller and smaller and smaller until it's able to do a gas exchange with every single aspect of your lungs. Here below it, you can see what the actual alveoli sacs look like. And then, of course, over here, it's kind of zoomed in, so you can see what it actually looks like. And you can also see that it has different types of cells, type 1 and type 2 alveoli cells. Type 1 is the one that will actually do the gas exchange. So it's all about allowing oxygen in and carbon dioxide out. Type 2 is going to be what we call a surfactant cell production. Surfactant is a glycolipid that's going to allow the alveoli to stay afloat, to stay nice and open, so that you can maximize your gas exchange. The reason it's so important is because we have a thin layer of water that sits across the opening of the alveoli. And the water is essential because it allows the gases to be extracted from the atmosphere and enter into the circulatory system. So the solubility of the gases is very important because it has to pass through this water layer. But the water layer also makes it more likely that these very fragile alveoli will tend to collapse on top of each other. So we need that surfactant to kind of force it open so that we are consistently able to do gas exchange. I've also highlighted the diaphragm muscle in our little mammal over here, and the main reason for that is because that muscle is going to be our prime mover for when we want to inhale and also to a point when we want to exhale. So I definitely need to mention the fact of how we get air in and out, and we'll do that in a little bit, but for now just concentrate on the fact that you want to get down to the alveoli because that is where you're going to actually do your gas exchange. Now, the lungs are protected by a pleural sac, very similar to what we saw when we were discussing the circulatory system and how the heart has a little pericardium sac. So you have a pleural sac that sits around the lungs. It's almost like a double Ziploc bag that has an outer layer and an inner layer. They'll fold in between themselves to give you a little pleural cavity that's filled with a little bit of liquid that helps with the reduction of friction, and it also helps with compartmentalization, so it makes it harder for disease models to infect one organ after the other. It will also help lubricate the lungs, making it easier for it to expand and come back to its original shape. We also see that the utilization of the pleural cavity will create a pressure point. And the pressure points are going to be very important because your lungs, unlike your heart, are not able to expand and relax and come back to their original shape naturally. They're going to have to rely on muscle control, in essence, to contribute the changes of their thoracic cavity, which will then correspond with changes in pressure, which will then correspond with you inhaling or exhaling. And I'll explain this to you in a little bit more detail on our next slide. But for now, I just want to kind of show you that some of the pressure that's needed to keep the lungs afloat is due to the fact of the pleural sac interplaying with its two different spaces. Now, we've known that if the patient loses the pressure point, it has a tendency to cause pneumothorax, which means that the lungs will collapse. And obviously this can be very dangerous because it minimizes to completely halts your gas exchange. So that pressure difference is very important, and we need that at all times to make sure that the lungs are kept inflated. All right, now how exactly do we inhale? How exactly do we exhale? We know we have our lungs, we know we have our diaphragm, we know we have our intrapleural pressure point that's going to keep the lungs afloat, but how do we actually explain the movement of oxygen in and carbon dioxide out? Well, as I mentioned to you before, the lungs themselves are not able to expand and constrict by themselves. So instead what we're going to do is we're going to alter the thoracic size. And as we do so, we're going to go ahead and be able to create a pressure difference. Now, the pressure difference you want to think about takes us back to our previous chapter where we talked about blood flow. And I said to you, when blood flows, it likes to go from a high pressure, right, to a low pressure. That's what it prefers. That takes the least amount of effort. So what we're going to do is we're going to take that same exact concept and we're going to apply it now to the respiratory system, and we're going to use it to explain how we inhale and exhale. So, few things to remember. We always want air to flow from high to low, and the air quality that, or the air pressure that we're going to be comparing is going to be atmospheric, so what's happening on the outside, and intrapulmonary, or in case of your notes, they also like to call it intrathoracic. So if you hear me say pulmonary pressure, if you hear me say intrapulmonary pressure, if you hear me say intrathoracic pressure, it is all the same thing. It all depends on the pressure that's happening inside the lungs. Now, disclaimer. There are obviously also other things that will contribute to the pressure point. For instance, we just talked about the intrapleural pressure that's being created by that layer, that pleural cavity that covers the lungs. These will play a role in the pressure differences as well. But the main ones are going to be between the atmosphere and the intrapulmonary, what's happening on the inside of the lungs. So those are the two that I'm going to concentrate on. And what I want you to know is that if you need to inhale, right, if you want air to flow from the outside to the inside, then what we need to happen is that the atmosphere needs to be high, and the intrapulmonary pressure needs to be low, because that's going to allow you to go from high to low, because that's our inhalation, right? Air goes in, so the high pressure point is atmospheric, and the low pressure point is intrapulmonary, aka intrathoracic. How do we do this, right? Because we can't really alter the pressure of the environment around us. What we can do is we can alter the pressure of the lungs, and you can do that by changing the volume of the lungs, because it turns out that as we increase the volume, look what it does to the pressure. The pressure decreases. It is an inversely related relationship. So as the volume goes up, pressure comes down. So if I now want to inhale and I want to have a low pressure in my lung, then the easiest thing for me to do is to expand my lungs, expand my thoracic cavity so my lungs can inflate as best as they can. Now, in order to do that, that is where your diaphragm muscle comes in. So you see this little dome-shaped muscle? All right, that's what the diaphragm naturally looks like. When it contracts, it falls down flat. This is what the muscle looks like when it's contracted. So notice how it went from up to down, and when it fell down, look what it allowed for the lungs to do. It allowed the lungs to expand, creating a larger volume, a larger cavity, and at the same time when the volume went up, then we now know that the pressure will go down. So this will create a low pressure point on the inside of the lungs, which then means that the air that's sitting outside in the environment is exposed to a higher pressure difference, and we're able to go from high to low. So you're able to inhale. So to summarize, if you want to inhale, and we're looking at our mammalian model, we are going to need our diaphragm muscle to contract. We're going to need the volume of the lungs to expand to increase. This is going to lower the pulmonary pressure or the intrathoracic pressure, aka the pressure that's inside the lungs. And due to that, it's going to allow the atmospheric pressure, the air outside, to be higher than it is on the inside of the body. So airflow will be from high to low. It will enter into the system. Now, we're going to reverse this whole item in order for you to do your exhalation. But I just want to mention something that I forgot to say to you before we kind of move on to exhalation. In order for your muscles to contract, it will require a motor neuron stimulation. So the motor neuron will have to tell the diaphragm to contract, but it does this consistently. So the diaphragm is consistently going up or down, and along the way changing the size of the thoracic cavity. Now, when it's time to exhale, we're going to actually have to put not as much effort into it. It's less effort to exhale than it is to inhale. Part of that is exhalation is basically just resetting the system back to normal. We see that the nerve stimulation will stop. We see that the muscle will relax, and when the muscle relaxes, it goes from flat, it pops right back up to the dome shape, right? And when it does that, what's going to happen with the lungs? The lungs are going to be compressed. There's going to be less space for them because the cavity has moved up again. And when it does that, it basically squeezes the lungs, it makes it smaller. And look what it says right here. It says if the volume of your thoracic cavity and your lung decreases, what happens to the pressure on the inside? It increases. So your pulmonary or your intrathoracic pressure starts to rise. And at a certain point, I'm going to draw these little makeshift lungs here on the side. And there's my little diaphragm. Looks like a sad face. At a certain point, because my lungs have compressed and they're back to their original size, what we see happening is that the pressure starts to increase. So it has high pressure on the inside. And at a certain point, the pressure on the inside will be higher than the atmospheric pressure on the outside. So what are we going to see happening is that once again, the air will respond by going from high to low, which means it's now going to cause you to leave the lungs. So this is your exhalation pattern. So exhalation pattern means that I am resetting my diaphragm. I'm making it dome shape again. This will cause the overall size of the lungs to compress because they have less room, so they'll be squeezed into a smaller volume. When the volume goes down, the pressure intrapulmonary or intrathoracic goes up, and eventually the pressure is higher on the inside than it is on the outside, allowing air to flow out of the body. This is one of the reasons why I said to you that exhalation takes less effort than inhalation. Because when you inhale, you need the nerves to stimulate the muscles, you need the muscles to contract, and then you need to go ahead and change the size of the thoracic region to create a pressure difference. Whereas when you're exhaling, you're simply just stopping the nerve signal, you're restoring or relaxing the muscle back to its original stand, and then you are obviously also changing the thoracic cavity or the volume so that you can now accommodate a reverse amount of air, meaning that it's exhaling out of the body. And we see that the lungs are able to do this, relatively quickly because they do have an elastic recoil to them. So they're not able to do this automatically, but they do have the elasticity that will accommodate the changes in your muscle tone as well as the halting of the nervous signal. Now, in case you're wondering, do you only use your diaphragm? No, there are different muscles that you can utilize. So for instance, just like with the reptiles, you can use your intercostal muscles, the muscles that are between the ribs. You can use your pectoralis muscle, the muscles that make up like the pecs where the breasts sit on top of it. It all depends if you're going to do a regular inhale, a regular exhale, or a forced inhale, a forced exhale. Whenever you force your respiratory rate, it usually means that you need to have a more drastic pressure change, which means that you're going to recruit more and more muscles so that you can manipulate the volume of the lungs appropriately. Now, speaking of our lungs, what we see happening is that the amount of air exchange that you can do will obviously depend on the pressure changes and the movement of the muscle, but the lung itself will also have some interplay on its willingness for gas exchange, because we have to look at things like lung compliance and surfactants. So the lung compliance basically means how easily do the lungs stretch when they inhale. If you have a nice, young, healthy lung, usually you don't have any issues with it. But for instance, patients who have COPD, who may have had lung cancer, who might have some fibrosis or scar tissue in their lungs, maybe from some pneumonia that they suffered on during their lifespan, what we see happening is this will lower your compliance, making it less flexible for the lungs to increase when you're inhaling or exhaling. This obviously will reduce your air exchange that you're able to do with each breath. Elastance, if you see that term, that basically means how willing is the lung to come back to its original shape. So the formation or the return to the original shape basically goes hand in hand with the compliancy of the lungs. The other item that's going to be a huge player are the surfactants. Now remember, the surfactants are the glycoproteins that I briefly mentioned on our previous slide. They're the ones that are going to keep the alveoli afloat, because we know that we have that thin layer of water that sits on top of it, and we need that water for the gas exchange to occur. And because water has a cohesive property, that means that the water will start to interact with itself, closing or drawing close the alveoli. Think of it as trying to have two wet sheets of paper, and if you now kind of attach them to each other, if you were trying to pull them apart, you're going to have a really hard time, because the water tends to stick to itself, making it hard to separate two wet pieces of paper from each other. So the best thing to do is to generate that glycoprotein, that surfactant, and the surfactant will keep everything afloat by loosening the cohesive property of your water molecules. In fact, the surfactant is so important that that's one of the main issues that we come across with preemies, because babies rely on their mother's oxygen and carbon dioxide gas exchange while they're in utero. What we see happening is that their lungs do not fully develop, and surfactant isn't produced until a few days, weeks before childbirth occurs. So if the mother has any complications and gives birth to a preemie, part of what we need to do is we need to make sure that the lungs can ventilate themselves. And if they can't, then we do know that there are some artificial surfactant medications out there that can take the role of naturally produced surfactant until the baby is grown enough to produce their own. They will also try to pump the mom full of different steroids, such as corticosteroids, all in an effort to kind of manipulate the baby's growth rate, speed it up a little bit so that the lungs can be as robust as possible, thereby increasing their chances of survival, especially if they're born in their preemie status. Another thing that you can discuss when it comes to airflow is, so we had our compliance, we had our difference in pressure changes, we had our surfactant. The other thing that we can discuss is what we call air resistance. Resistance is going to slow down the flow, because what's going to happen is as the air flows through the trachea, into the bronchioles, into the lungs and back, the air will go ahead and encounter laminar flow, meaning that in the center lumen of your bronchioles and the trachea, the air will flow the fastest. The air that's on the side of the lumens will interact with the lumen wall, which creates a resistance which will slow it down. So if you want to speed up your air, you want to do things such as bronchial dilate. Make the bronchioles nice and big in diameter so you have lots of laminar flow and the air can get there quicker. If you want to limit your airflow, then you're going to do bronchial constriction, which means that you narrow down the lumen so that there's more resistance that is being experienced, slowing down your airflow. On your PowerPoint, I did write down for you that a lot of times your parasympathetic nervous system will cause bronchial constriction. We see this, for instance, when people are having an allergic reaction and their body secretes too much histamine. It can go over to the lungs and it can go ahead and cause bronchial constriction, which is then correlated with like something like an asthmatic attack. So how do we combat that? Well, a lot of us with asthma walk around with an inhaler, which is basically an antihistamine and a bronchial dilator. So it will reverse it and open it up. Sometimes your body will naturally do bronchial constriction if it thinks that there is a pathogen or an allergen that is that's on the loose and has the potential of infecting your lung tissue. Your sympathetic nervous system, on the other hand, because it's an antagonist to the parasympathetic, will often cause bronchial dilation. So like, for instance, we'll see that whenever your body is flooded with high levels of carbon dioxide, because it tries to get rid of that excess CO2 as fast as possible. And also epinephrine. So when we do things like exercise, we're going to notice that our breathing rate is adjusted, and part of that is all the epinephrine that's flowing through our system will actually assist us with bronchial dilation, so we can do our gas exchange at a faster rate. Something else to consider is what we call dead space. So when you inhale your air, and it travels from the oral cavity and the nasal cavity over to the pharynx and the larynx and the trachea and into the bronchioles. As the air is traveling, it's not really doing any gas exchange. So we like to call those regions that it has to move to before it can actually get to the alveoli, we like to call that dead space. And the air inside is dead air, because the air is there, but you're not utilizing the oxygen into your bloodstream and carbon dioxide out of it. That will only happen within the alveoli region itself. So, what does this mean? Well, first of all, we often can go ahead and calculate an organism's tidal volume. A tidal volume basically takes a look at what is the average amount of air that moves in or out during a regular inhalation or exhalation. For humans, a lot of times it's 500 mLs. So if I were to hook you up to a spirometer and tell you to go ahead and do a regular inhale, most of us would suck in about 500 mLs of air. And that air will encounter dead space initially as it travels through our upper respiratory tract, and it really won't become useful to us until it reaches the alveoli. So over here, I have a little picture of a crane, and what you can see is that he has a relatively long neck as well as a long trachea, a long way to go for the lungs. So he has quite a bit of dead space. He has quite a bit of anatomical dead space because of the volume and the length of the trachea and the bronchioles. In addition to anatomical dead space, you can also have alveoli dead space, and this has to do with the fact that some of us might experience damaged alveoli that can't be repaired, that just kind of sits there, but doesn't do any gas exchange. So in case you have any damage to the lungs and the alveoli, your dead space would be a calculation of your anatomical dead space as well as your alveoli dead space. If your lungs are working at full capacity, then the only dead space that you would encounter, or the only dead air that you would hold on to, would be within the anatomical dead space. So it would be only in the pathway that it has to travel before it gets to the lungs. Now, because animals like cranes or like giraffes have a high amount of anatomical dead space, usually what we see is that their body will compensate by increasing their tidal volume. So they'll suck in more air with a single breath, because we know that the air has to travel far before it can actually do its gas exchange. Another thing that we should definitely mention is if you are successful in getting air into the body and allowing it to diffuse across the alveoli, how do we now get the oxygen to actually bind to the blood? Well, a lot of it we see has to do with the metalloproteins, or little respiratory pigments that we'll utilize. And a lot of these will increase our affinity and our ability to hold onto our oxygen molecule, so it can be very beneficial to the body. Turns out there are three major types: hemoglobins, which I know many of you are familiar with, hemocyanins, and hemerythrins. So let's take a few seconds and let's just sort of compare the three from each other. All right, so first one is hemoglobin. Hemoglobin is what you would have in mammalian models such as ourselves. Most vertebrates have it. We also see it in some annelids, insects, crustaceans, and nematodes. And when you look at the hemoglobin format, we see a combination of globulin proteins, and we also see our heme group. Now, the globulin proteins will come into a pair of two different chains. We have our alpha and we have our beta subunits. So you can see these little tubing of red and dark red. Those are going to be your globulins. So those are proteins. So you have two alpha and you have two beta. And what we see happening is that we have our little heme group. At the end, this little yellow flower, and at the heme group, we have a little red dot. You can see it over here, a little bit darker. That is where we're going to have our iron. It is important to point this out because it turns out that each heme group will be able to accommodate one oxygen molecule. So that means that one hemoglobin can accommodate 4 oxygen molecules. And there are thousands of hemoglobin in every single red blood cell. So think of the iron almost like a little magnetic force. If you have a lot of iron, it makes it easier to locate the oxygen and carry it. If you're low on iron, then it makes it harder to attach and transport the oxygen. So some of us might be diagnosed with anemia, meaning that we have low levels of iron. It could also mean low levels of red blood cells. But for many of us, it means low levels of iron, so that even though we're inhaling our air has a hard time binding to our oxygen and being transported because we're missing that iron content on the heme group. Now, an interesting thing is that as soon as the red blood cells attach to the heme group, they will go ahead and appear red. The redder the red blood cells, usually the higher levels of iron it's associated with. So that's pretty cool. We also see that hemoglobin comes in different types of isoforms that have been specialized based on the tissue that they're supplying. So for instance, if you see myoglobin, that tends to be the version that you come across in your muscles. And if you ever hear of neuroglobin, that's the one that you tend to have in your nervous system. I also want to point out that when a baby is in utero, so it's still in mom, waiting for its development, what we see happening is that the baby's hemoglobin is a different composition than the mother's hemoglobin. Instead of having beta chains, it will have gamma chains. So it will have 2 alpha, 2 gamma chains for its hemoglobin. And in case you're wondering, well, what's the difference? Well, it turns out by swapping out the beta with gamma, it actually increases a higher affinity point, making it easier for the baby to quote-unquote steal the oxygen from mom's heme group and allow it to transfer to the baby's heme group. If both mom and the baby had 2 alphas and 2 betas, mom's system would always win out. So the baby needs to have a little bit of a stronger pull, which it will have by substituting the beta with the gamma. And then in case you're wondering about the next one, once the baby is born and starts breeding on their own, what we see happening is that the hemoglobin that's produced afterwards will be consistent of 2 alpha and 2 beta. So it will switch back to the quote-unquote normal format once the baby is born and breeding on itself. So there's no more competition for that gas. Hemocyanins are what we come across in arthropods and mollusks. They will go ahead and utilize copper instead of iron. A lot of research has shown that they have have independent evolution amongst the group that use hemocyanins. We also see that it will tend to dissolve in the hemolymph, and instead of appearing red, it will give more of a blue coloration when it interacts with the hemolymph. The Hemerythrins, which is our bottom selection, those are usually seen in different invertebrate models, but they've also seen them in some annelids. They will utilize iron, but they won't use the heme group. So the iron will directly bind to the globulins, to the protein. They will also have more of a violet pink color that will come into play when the pigments interact with the blood cells. I also want to quickly mention that if you take a look at the chart that's on the right-hand side, it talks about the fact that you do have a saturation point within the hemoglobins, which kind of makes sense because if you run out of hemes, to bind to, there's no way that it can go ahead and increase the saturation rate. And the reason I want to point this out is because it turns out that as soon as you have one oxygen molecule that binds to one heme group, the hemoglobin will actually change or configure its shape to make it more likely for the second oxygen molecule to come in contact with the second heme group. And once that happens, then it makes it more likely for the third one to come in contact and up until the fourth one, because each hemoglobin can carry 4 oxygen molecules. And this is a really nice example of a positive feedback system where it will basically encourage the saturation of the entire respiratory pigment. I also want to mention that the affinity, so the attachment or the willingness of oxygen to attach to the hemoglobin, can be altered. It can change. One thing that can change it, for instance, is temperature. The higher the temperature, the lower the affinity. So why would this be useful to us? Well, for instance, when you're exercising, your body usually runs hotter than normal because of all of the metabolic heat that you're generating. And as the body becomes warmer, we see that the affinity between the oxygen molecule and the heme group starts to lower a little bit. And in case you're going, is that good or bad? That's actually a good thing, because if the oxygen isn't tightly bound to the red blood cell, that means that as the red blood cell is transporting it, it makes it easier for the oxygen to be released from the hemoglobin and go directly into the body tissue that requires it now, probably at a higher rate because you're exercising. On the other hand, when we look at things like carbon monoxide, we have to be very careful because carbon monoxide will compete with oxygen to bind to the same hemoglobin and heme groups. And it turns out that carbon monoxide has a much greater affinity than oxygen. I believe the last paper I read said that carbon monoxide is 200 times more likely to bind to the heme than oxygen is. So if carbon monoxide binds to the heme, that means that there's nowhere for the oxygen to bind to, which means that it lowers your oxygen saturation in the body, which makes carbon monoxide such a dangerous poison to have around, and how it can cause death in patients that are exposed to high levels of it, because the oxygen cannot properly bind and be transported throughout the tissues in the body. One last item that I want to mention, and this is a very important one, is going to be the role that carbon dioxide and pH play with each other. And the reason I want to bring this up is because, as many of you know, you inhale your oxygen and you excrete your carbon dioxide. The reason that you have carbon dioxide is mostly due to cellular respiration, when we go ahead and utilize like our glucose molecules to go ahead and convert them into ATP molecules, or extract the energy from the glucose and transfer it to ATP molecules. When we do this, when we do our aerobic respiration, one of the side products that we generate is carbon dioxide. And what we see is, unlike oxygen, carbon dioxide likes to be more of a free-floating gas. Does it have a binding site on oxygen? Yes. Is it different from oxygen? Yes. So it doesn't compete, but carbon dioxide tends to be more soluble, so the majority of it will be found in what we like to call bicarbonate, meaning that it can freely interact with the water molecules in your body. And what I want to do is I want to quickly show you this little chemical formula, and it basically says that carbon dioxide normally interacts with water, H2O, and it starts to generate carbonic acid, which is this right here. And then the carbonic acid will then quickly break down and become bicarbonate, as well as free-floating hydrogens. Now, in case you're going, what does this have anything to do with the respiratory system and pH? Well, let me go ahead and give you a quick reminder of pH. When you look at the pH of a solution, you are basically comparing hydrogens versus hydroxide molecules. And what we see happening is you can have 3 relationships. They can be equal, meaning you have a neutral environment. You can see that your hydrogens exceed your hydroxide, which means that you create an acidic environment, or you can have that your hydroxides exceed your hydrogens, which means that you have more of a basic alkaline environment. Now, what is our homeostatic pH that we come across in the bloodstream and your cerebral spinal fluid? Any guesses? If you said around 7.3, you're good to go. So our natural homeostatic pH is around 7.3, 7.35, I believe it is. Now, the 7 is the most important one because 7 means it's neutral. So on a regular, typical day, while everything's going well with your body, the amount of hydrogens is equal to the amount of hydroxide ions that we have. And a major source of the hydrogen ions is coming right here from this little formula, which is controlled by how much carbon dioxide you have in your body, okay? So your body has to be careful not to hold on to too much or too little, because that's going to fluctuate how many hydrogen ions you have, which can fluctuate your overall pH, which can lead to respiratory alkalosis or acidosis, which can cause anything from you losing homeostasis to you becoming unconscious, going into a coma, and it could actually be deadly to the patient. So we want to make sure we stay nice and neutral at all times. However, we do know that there have been cases where you go into what we call hypercapnia. Hypercapnia means that all of a sudden you have extremely high levels of carbon dioxide. If you have high levels of carbon dioxide, that means that you also start increasing your concentration of hydrogens. So what happens if your hydrogens go up, meaning that they start to exceed how many hydroxides you have? Well, if that happens, then your pH drops and you go into more of an acidic range. This is very dangerous. We don't want that to happen. So what can your body do to get rid of all that excess carbon dioxide, right? Because your carbon dioxide went up, your hydrogens went up, and now you're in an acidic range. Well, what we can do is we can turn to our respiratory system and we can change our ventilation rate so that we can get rid of that carbon dioxide that we have in excess. We can get rid of it quicker. So what we're going to see happening is that your body is going to respond to high levels of CO2 by hyperventilating. And when you're hyperventilating, you're basically speeding up your exhalation pattern so that the carbon dioxide is expelled faster and can hopefully go down and go back to its normal levels. Now, we can also see the opposite trend. What if you go into hypocapnia? In hypocapnia, your levels of carbon dioxide fall way below what they normally need to be. And according to our formula, if the carbon dioxide is low, that means it's not producing enough hydrogens. So in this case, what we see happening is that the deficiency of carbon dioxide and the deficiency of hydrogens can cause the hydroxides to exceed the hydrogen. And if that happens, our pH goes up and we go more into alkalosis or more into a basic or alkaline pH, anything above 7.3. Now, how are we going to solve this? How are we going to get the body to go ahead and adjust its respiratory rate so that we don't lose more CO2, right? Because we're into alkalosis because we have low levels of carbon dioxide. Well, in that case, what the body will do is it will lower its ventilation rate. So it's going to do hypoventilation. It's going to allow you to inhale normally, but when you do your exhale, it's going to be very brief and very short. And that's going to minimize how much CO2 you lose so that your body can start working on restoring the carbon dioxide ratio that you have floating around in your bloodstream. And as the carbon dioxide gets restored, then the hydrogen becomes restored, and eventually it will start equaling out how much hydroxides you have as well. Now, I added a little paper bag into this slide. The question is why? Well, that's because when we see happening is, it doesn't always mean when you change your pH, it doesn't always mean that your carbon dioxide levels are not being regulated properly by your homeostatic properties. There have been cases where you can have your patient that comes in and, for instance, they have an anxiety or a panic attack, and that causes their breathing rates to be altered, and that can then indirectly affect their carbon dioxide reaction. What do I mean with that? Well, imagine if you come across someone who's having a panic attack. When someone starts panicking, usually what we see is that their respiratory rate can have a potential to be increased drastically. So they start hyperventilating. And when you hyperventilate, that means that you start losing massive amounts of carbon dioxide. And what happens if you lose too much carbon dioxide? Go back to this line right here. Carbon dioxide goes down, which means that my hydrogens go down, which means that I can go into alkalosis. I don't want respiratory alkalosis. So what I'm going to do is I'm going to hand my patient or whoever I'm assisting with their panic attack, I'm going to reach them a paper bag. And the reason for that is, as they inhale and exhale at an expeded rate, the paper bag is going to serve two purposes. One, it gives them something to focus on so that they can start controlling their breathing cycle as the bag inflates and deflates. But also, all that excess carbon dioxide that you're pushing out because of their hyperventilation, because it's kept into that paper bag, you suck it right back in when you inhale. So it's an excellent way to maintain your overall CO2 concentration, because whatever you exhale, you inhale right back out. So I guess the joke is, make sure that you don't give them a bag with a hole. No? Okay. I try. All right? So take a look at this slide. I know I wrote a lot on it, but basically what you want to remind yourself is that CO2 is related to hydrogen. If my CO2 goes up, my hydrogen goes up, so then therefore I become more acidic. So how do I get rid of that excess CO2? I hyperventilate it out. So I exhale faster. If my CO2 is low, then my hydrogen is low, which makes it more alkalosis. So now I want to hold on to as much CO2 as I can. So I'm going to do hypoventilation. I'm going to lower my rate of exhaling so I can save as much CO2 as possible. Beyond that, I think that we're okay to go. One thing that I want to mention. On your slide, you're going to notice, for instance, if we come over here, notice how it says PCO2. So P refers to partial pressure. And the reason that's important to point out, and I didn't mention it as I was lecturing, is, as many of you know, atmospheric air is a combination of different gases. It has nitrogen in it, it has oxygen in it, it has carbon dioxide in it. So hopefully when we were talking about inhalation or exhalation, some of you were thinking about the fact of, well, when I inhale all that atmospheric air, how does my body know that I only want the oxygen to go into the body? It all depends on the partial pressure of the individual gas. So what I mean with that is, whenever you inhale atmospheric air, by the time that air gets into the alveoli, what your body has figured out is that the partial pressure of oxygen is higher in the atmosphere than it is inside of your body. And it allows the oxygen to flow down the concentration gradient, so you're able to inhale it. On the other hand, the partial pressure of carbon dioxide is usually higher inside the body than it is in the atmosphere. So that is then why carbon dioxide is able to flow out of the body, because it goes from a high to a low partial pressure. So this kind of explains why you can inhale cumulative air, but the body will regulate the partial pressure of the individual gases you need to enter as well as to exit. All right, I hope you found the respiratory system interesting, and as always, I look forward to your questions, comments, and concern. Our next chapter that we're going to be exploring is going to be all about the digestive system. So we'll meet up soon again. Thank you.